Good day, I am Sherilyn Francis, and on behalf of Morehouse Healthcare Telemedicine Project, we welcome you to Part 2 of our Telemedicine webinar series. The mission of the Morehouse Healthcare Telemedicine Program is to advance health equity amongst minority and underserved communities by integrating healthcare technology advancements. I now present to you today's webinar entitled, The Influence of Policy on Virtual Care Delivery, presented by Ms. Megan Douglas, Dr. Chantel Branson, and Mr. Marcus Smith. In compliance with ACCME guidelines, the following presenters have no financial or other relationship with the manufacture of any commercial service discussed in this educational activity.
All right, well, good afternoon, everyone. Hopefully everyone can hear me okay. All right, so I want to start with the understanding the influence of the virtual healthcare. So initially, when telehealth first came out, the focus was to educate and bring specialized care to underserved areas, also saving time for the patient and its provider, as well as public health staff. Since then, we've kind of grown a little bit, and we also look at telehealth as a way to improve our cancellation and no-show rates. Majority of these issues that we currently see that deal with telemedicine are the gray areas that no one has explored, such as the payers. Some payers are flexible to the new telehealth, wave, and some are more so. We'll just lean to the understanding that Medicare, Medicaid, services provided to us by CMS guidelines. Telehealth growth. All right, so a little bit about the growth. So it said as of May 2019, we've seen 53% faster growth than any other place of care, which says a lot. Because in 2016, we only had 11 states that adopted telehealth and telemedicine. With the rapid telehealth growth, there's an increase in claims, as well as updated information and new telecommunications. So we're seeing a lot of that now with the, pop-up overnight telemedicine platforms. Telehealth growth and the payers' reaction to that growth. All right, so this is a really interesting point. There are several telemedicine platforms that are available to you. However, several have been aggressive about being proactive in the telehealth wave. Global Med, MD Live, Amwell, Doctor on Demand, eVisit. So I picked these couple of telehealth platforms out simply because they've taken a different approach than a lot of other platforms that are available to us. MD Live, Amwell, they've partnered with Cigna, and they're saying that, and Cigna is saying that the only way we'll reimburse for our visit, for the patient's visit, is if you use an MD Live, Amwell platform. I think Blue Cross Blue Shield is using Doctor on Demand. So the impact that telemedicine is having on the policies. Earlier this year, we've invited 50 states to be a part of the live video for telemedicine reimbursement. This was given by AMA. Spring of 2019, the Center of Connected Health and Policy met with the state policymakers and early interested healthcare professionals to serve as a telemedicine advocate, which is really phenomenal. A lot of people are kind of skeptical about telemedicine and where we're going with it. Lawmakers were encouraged to pour into this idea and embrace telemedicine through policies, law, regulations, and now it's in all 50 states, including District of Columbia. The next steps on telemedicine improvement. All right. So CMS has partnered with AMA to establish a digital medicine payment advisory group known as DMPAG. They're working to improve innovation, regulations, code, pricing, coverage, liability. Additional areas of focus will be coding and payments, digital medicine matrix, augmented intelligence, and advocacy focus groups. All right, so with coding and payment, they're creating a taxonomy code for digital health. They're reviewing the face-to-face service definition in the age of digital medicine, which is a big step. So performance measures for these encounters. CMS is currently working to design a measurement tool that will measure clinical performance, member experience, drug adherence, operational efficiencies. There will also be performance measures for closing the encounter. There will be a total of 44 measures across 5 domains. These domains are outlined as healthcare effectiveness, data and information set, consumer assessment and healthcare, providers and systems, health and outcome surveys, Part D, and operations. All these will be put into a matrix tool that will allow CMS as well as some others, AMA, to define a phenomenal healthcare experience via telemedicine. In addition to performance measures for closing encounters, the most common obstacles that were identified, CMS hired a Collier Healthcare Consulting Company to identify these obstacles that many people are facing that basically prohibit the closure of encounters. Some of the top ones were appointment availability for members of the providers, for members and providers opening. What that's saying is that you have a provider that has an open time slot on their schedule, however the member is not able to see them for whatever the reason. A lot of times this is due to the support that's required in order to set a telemedicine visit up. Claims are submitted without ICD codes and the appropriate CPT codes. This will count towards the measure. Provider especially does not count for this measure. Certain measures do not meet date parameters, such as completion of child immunization on or before the 2nd birthday. Members are assigned to the wrong primary care physician, and the information is not transferred to the new primary care physician accurately. Now we're going to get into the rating system that CMS is working to establish. It will be based on a star scale, 1.2 stars. You basically have a plan, a cap put on your plan. If you get between 3 to 3.5 stars, that's just saying that, hey, you meet the minimum requirements, good job, work to improve your efficiencies. If you receive 4 to 4.5 stars, that's saying that you'll receive 5% on each member per month of their reimbursement, the total reimbursement. 5 stars saying that, hey, you're a stellar performer. You'll receive 5% per member per month, and you'll also have year-round open enrollment. All right, so I want you to take a note of that year-round enrollment. All right, so the calculation breakdown here. I know I said it's 1,200 patients per month, but we're going to keep it simple and say 5,000 patients per month. I think that's more realistic. So if you receive 4 to 4.5 stars, you'll receive 5% plus per member per month reimbursement. All right. So say, for example, you see 12 patients for the month. You times that by the 5%, you will receive a reimbursement of $60 as a reward towards that month. Now, currently, they're not saying what you can use that $60 for. However, you can also use it for provider incentives. You can also use it for telemedicine enhancement. So basically, reinvesting in technology to improve your current systems. All right. If you receive 5 stars, and you'll receive 5% per month per member, plus year-round enrollment. All right. So the reason why I wanted you to remember the year-round enrollment, because that's where you receive your kicker. All right. So say, for example, you receive that $60 a month, and you've been maintaining 5 stars. For the year, you receive a reimbursement of $720. So everyone who receives the 1 star to 2.5 stars, they will lose the patients that they have in their telemedicine pool, and those patients will be divided amongst those surrounding telemedicine providers in the area that receive 5 stars or greater. All right. So, for example, if you normally see 5,000 patients, the pool contributions a year, $720 will be times by that 5,000 patients that you received from the underperforming star performers, and so that would equate to $3.6 million.
Megan Douglas. I am on faculty here at Morehouse School of Medicine in the Department of Community Health and Preventive Medicine, and also the Director of Health Policy for the National Center for Primary Care here at Morehouse School of Medicine. And I guess I can give my disclaimer here too. I am an attorney by training, but I am not providing legal advice during this presentation. I wanted to introduce the audience who is not aware of the National Center for Primary Care. We are located here at Morehouse School of Medicine and do have a number of different programs, some focusing on building capacity within primary care systems to treat addiction and substance use disorders. We are also home to the Georgia High Tech, which has assisted providers across Georgia adopt electronic health records and health information exchanges, and we also have a practice-based research network of primary care associations and community health centers across the Southeast region. And I also wanted to take this opportunity to introduce a new project that we are working on, examining health IT adoption by primary care clinicians. This is a project funded by the United Health Foundation, and we are examining this health IT adoption in 4 states, Georgia, North Carolina, Kentucky, and Tennessee. We'll be conducting focus groups and an electronic survey to assess what types of technology is being adopted, how primary care clinicians are using the technology, and then barriers and facilitators to adoption. We will also be comparing the state-specific landscapes and practice landscapes to identify factors that have been either positive or negative in assisting primary care practices to adopt. So I'm hoping that in the next few months you'll see some information about this survey, and primary care clinicians who are on this webinar, we would love to have you participate. So this is where the presentation is not providing legal advice, but I did want to talk through some of the questions that people may be having as they're preparing to practice telemedicine in Georgia. And some of those questions, especially looking from the policy perspective, are who will you serve, and thinking about that from what type of payer or payer mix you may be interested in serving. Who will you bill? So with the same idea in mind. And as you will see this as this presentation proceeds, these questions are relevant to which types of Georgia policies and laws you'll want to be aware of. Thinking about whether you will be the distant site or the originating site or both, and who you will partner with. In other words, who would be the distant or originating site that you would be working with. So in order to answer some of those questions, it's really important to understand the Georgia telemedicine policy landscape. So in the next few minutes for this presentation, we'll talk a little bit about the Georgia Telehealth Act and other related laws. This is really an exciting time in Georgia, the 2019 legislative session. We saw a number of different bills pass that are going to, I think, advance the use of telemedicine in Georgia. We'll also talk a little bit about the Georgia Composite Medical Board. They regulate the practice of medicine in Georgia, so rules and regulations from the Georgia Composite Medical Board apply regardless of what type of payer you may be working with. And then Georgia Medicaid, they have a number of telemedicine-specific rules and regulations in the provider manual. And then I will not be talking about Medicare today, since I will be talking about Georgia-specific policies, but Medicare also has its own set of unique rules relevant to whether providers can bill Medicare for telemedicine services. So just starting with the Georgia Telemedicine Act, Georgia was actually relatively progressive in advancing telemedicine. We passed the Georgia Telemedicine Act in 2005, and this law defined telemedicine and also required insurance parity, so required private payers to pay for covered services that they would otherwise cover if they were delivered via telemedicine. In between, since 2005, we have seen a rapid adoption of telemedicine across the state, and soon after that law was passed, private payers, there was a slow transition to get all of the different payers on board for paying for services appropriately, but it does sound like a lot of that insurance parity and payer parity is coming to fruition more. But then in 2019, the Georgia Telemedicine Act was amended and is now called the Georgia Telehealth Act, so it is much broader than simply telemedicine. It becomes effective on January 1st, 2020, and it did redefine telehealth and telemedicine. So the law before this expansion had a very narrow definition of telemedicine, but now the law includes definitions for remote patient monitoring and store and forward, and it defines distant and originating sites, which the law did not do in the past. In addition to the payer parity law or parity mandate that was in the original bill, this law also specifies that that reasonable compensation is required. So what was happening was that the originating sites were not getting compensation from payers, at least not on a systematic basis. So this law would require that reasonable compensation be made for both the distant and originating sites. And then we also, in the 2019 session, had the Georgia Medical Practice Act, which authorized the Georgia Composite Medical Board to issue telemedicine licenses to physicians licensed in other states. So some of the issue with expanding telemedicine within Georgia is that we already have a shortage of healthcare providers within the state. So identifying providers outside of the state who could see patients within Georgia is one of the issues that this law was meant to address. We also have other issues, even with providers and matching primary languages with the patients. There have been examples of needing to work with providers in other states that may speak the same language as an individual patient here in Georgia, and the prior law was preventing some of that being able to happen. And then we also had in the 2019 session the Interstate Medical Licensure Compact. So this allows for expedited licensure in Georgia for a physician that's licensed in a member state. Now this compact may have much broader implications than just for telemedicine, but this trend in adopting the compact has aligned a lot with providing telemedicine services. So this is a compact that I'm not sure, I can't remember how many states are now a part of it, but it's been rapidly expanding across the nation. And for states that are, whose legislatures have agreed to join this compact, it expedites that licensure process across those states that have recognized this compact or joined it. So in addition to the state laws or state statutes that I just went through, we also have the Composite Medical Board who regulates the practice of medicine. They do have a telemedicine-specific rule, a couple of telemedicine-specific rules. The first one is this rule section 363.07, and it requires that a Georgia license in order to perform telemedicine services. And then it also has a pretty specific definition about the examination requirement, or how the provider sees the patient. So, and this is where you see a lot of variation across states, is how they regulate and determine the level of the standard that providers have to use in order to make sure, and this is more for patient safety, to make sure that the provider is able to provide appropriate care. So for Georgia's rule, the provider must have either personally seen and examined the patient. They may be providing care at the request of another provider who has personally seen and examined the patient, or they may be able to examine the patient using technology or peripherals that are equal or superior to the in-person examination. So making sure that those boxes are checked is really important for providing telemedicine services. And then there is also a regulation for telemental health. It establishes the minimum standards for delivery. It goes pretty in-depth on the training that is required for both the person that may be presenting the patient and also the provider at the distance site. So anyone considering telemental health or telepsychiatry, I definitely suggest that you take a look at that rule. And then just briefly, we'll talk a little bit about some of the Medicaid guidance. So the Medicaid program did put out new guidance for telemedicine July 1st of this year. It is available in the GAMIS portal, which I have the link here, and then at the end of my slide set, I have the full link in case what you receive you can't just click on. There are a number of technical requirements, so what parameters for internet connection, HIPAA, compliance, and some other technical requirements are included in the Medicaid manual. And just to highlight, there is no payment. Medicaid restricts payment to real-time services, so there is no payment for store and forward or asynchronous services. Medicaid, the manual lists the types of distant site providers, which this list has expanded over time. So these are the types of providers on the left side of the screen that can provide telemedicine services. And then it also includes a list of originating sites. As you see, there is no home for an originating site. So a patient does have to be presented by someone at a place listed as an originating site. And that's been an area of a lot of conversation and discussion, especially as things like at-home monitoring and the convenience factor of patients being able to be at home for telemedicine. But Medicaid, Georgia Medicaid is not covering services like that at this point. Just really briefly, some of the billing information. The GT modifier is still required for Georgia Medicaid. I do think that there are some changes happening with the modifier codes in the Medicare program, but as of now, the GT modifier indicates that the service indicates the distance site service was provided, and the GQ modifier is the originating site. And currently, Georgia Medicaid will pay $20.52 to the originating site as the originating site fee, and indicated by the Q3014 code. And there are different requirements for hospitals billing for the facility fee that are included in the manual. And then coverage requirements. Referring and consulting providers have to be enrolled in the Georgia Medicaid program. There are some pretty specific requirements around written consent that patients have to provide prior to rendering the service. And then the referring provider must be the patient's attending or provider in charge of their care. And then documentation has to be recorded by both the originating and the distant site. And then, again, there are some telemedicine-specific technology requirements with regard to HIPAA compliant. The manual does specifically say that Skype and a number of other platforms that are pretty common on an everyday basis are not appropriate for telemedicine and will not be covered. Okay, thank you.
Hi, my name is Dr. Chantel Branson, and today I'll be talking about the clinical practice guidelines for telemedicine implementation. So basically, just to get started, I wanted to provide my perspective as a clinician providing the services for telemedicine to my patients. So it may not directly apply depending on the type of physician that you are. I am a neurologist by training, and therefore my specialty is a little bit more focused, but I do want to provide some general information. With getting started with telemedicine, basically making sure that the office that you're in, the company that you're working with, or who is helping providing the services can assure privacy of the patient data, guaranteeing proper evaluation and treatment of the patient. So if you think that it might be a bit more complex, or more challenging, or you haven't been able to really grasp the etiology or cause of the symptoms that the person is having, then maybe that may not be a good person for you to see through telemedicine or telehealth. And also fully verifying and authenticating the location, and to the extent possible, identifying the requesting patient. So just understanding where you're going to have these type of services provided and making sure that the patient is clear on what they need. So whenever a person comes into my office and they're and I'm considering them for a telemedicine visit, I take several things into consideration. Are they living in a very far location from where my office is? Is it difficult for them to get here? Is it traffic? Are they not able to drive because of the specialty that I'm in? Or and then informing them that they would need some sort of a device to use, depending on the type of company or the telemedicine services that you provide. They would need either a phone or a computer, or understanding how to use something to communicate with the provider. So just making sure that they are aware, and at any time if they don't feel comfortable or if there are any issues, giving them the option to particularly changing back to an inpatient or in-person visit. So establishing patient-provider relationship, just to continue that, disclosing and validating the provider's identity and applicable credentials is very important, as discussed previously. Obtaining appropriate consent from requesting patients after disclosures regarding the delivery models and treatment methods or limitations, including any special informed consents regarding the use of telemedicine technologies. This might be more for the person who may have some memory problems, or might be considered someone who needs more support or understanding, may have some challenges with understanding the questions or how to use them in telemedicine, telehealth visit. And then just a few important considerations, important to ensure that you're able to do a proper evaluation, as stated before, understanding your patient population and the person that might be adequate for the type of study, evaluation or visit that you will be performing via telemedicine or telehealth. Consultation and then prescribed treatment are all thoroughly documented in the patient's medical record and electronic health record. So just making sure that you document it just like you would a normal in-person visit. If the evaluation, diagnosis, or treatment will be too complicated, as I stated before, for telemedicine service, giving them the option to request it, even after you've already decided that, and they have decided that they would be a good fit for telemedicine. If they call back or they contact you or the visit or the clinic, just have that option ready and available for them. So follow-up care. Follow-up care should be available to the patient, either telemedicine follow-up. So for example, for me, I do Botox. So I would perform the Botox for a patient who has any movement problems. That's my specialty or background training is in movement disorders or migraines, and then I may have them do a telemedicine follow-up in 6 weeks before the next Botox treatment or therapy is indicated, just to see how they're doing. So that would not You also have to be mindful of the time, depending on the company. Some companies have you do a 15 or a 30-minute visit. If it's more of a 15-minute visit, then, once again, this is something where it is a simple question or evaluation and not something that is more complicated. Also in-person follow-up and with another provider. Documentation from the visit should be accessible to the patient, and be prepared to share information with another provider of choice recommended by the patient. And once again, this is all very generalized information. You may or may not have a provider that you can share that information with. So just making sure that it's accurately documented in the EHR, in your electronic health record, so that everyone is clear about what the treatment evaluation was for. And once again, prescribing. Considering the possible absence of a physical exam, understanding that patient safety is so important. Once again, you're going to have to determine which patients would apply for you and decide if that person would be adequate to prescribe the medications via telemedicine or telehealth. And once you can start to do it, you'll get a good feel for it. Prescribing medications is considered safe by the physician state board. Also, you have to understand what laws are appropriate for your particular state that you live in. And all medications prescribed must be done at the professional discretion of the physician, as stated before. Telemedicine providers should have knowledge of the availability of medications in the patient's geographic location and the other providers caring of the patient. Caution should be exercised in prescribing medications that require close monitoring or that could lead to acute changes in a patient's condition, particularly if the patient is not in close proximity to a health facility or healthcare provider. And once again, this goes back to the discretion of your particular field in medicine, your patient population, and how it will relate to a telehealth or a telemedicine patient. So you would have to really, determine what your particular state, their laws, the state laws, and how it will work for your particular institution. Thank you. Thank you.
We are now open for question and answer. So we will begin with our first question, and this question is open to all panelists. And the first question is essentially, as a health professional, how do we get started? Where should we start if we're interested in implementing telemedicine services at our practice?
Dr. Branson, did you want to share how you got started?
Yeah, definitely. I think Marcus might be the best person for this because this is like, I'm sure there's a team working behind me doing all of the work, and I'm just like scheduling the patients and seeing them. But it does start with a great clinical support group, depending on if you're in private practice. They also have inpatient telemedicine and telehealth. I have to say I previously worked in Boston. It was a little bit more challenging to get the telehealth started at that location compared to here because, as stated before by Megan, there's just such a shortage of physicians, and it's just a larger state and area, so there are more locations that are needed to be covered, and there are just not enough physicians. So basically, I was able to get started through the clinical team at Morehouse Healthcare, and they were able to get me started enrolling that way.
Well, to piggyback off what Dr. Branson was saying, it's definitely, once we identified that there was a need for telemedicine, we started exploring those opportunities and then kind of looking and seeing what our, peers in the industry were doing, and that kind of solidified things for us. I think one key thing that you have to take away from the telemedicine piece is that none of it will be easy. And every turn that you make, there's an obstacle. And so just being flexible and understanding that, the best results come from those who actually are dedicated to improving patient care.
Yeah.
And I found that to help significantly.
Yeah, just to add to that as well. I mean, some of the, like I said, a lot of this is generalized. So you have to find a program and telemedicine, telehealth provider or services support group that works best for you and your clinical field or background. You know, while there may be incentives for one, there may not be for another, you know, so just evaluating that and making sure that you find one that works best for you.
And the only thing I'll add to that question, and that's why I kind of started with the approach of who you want the payer to be, and I know that's a process that has informed a lot of practices, you know, getting started, is sometimes it's easier to start with patients paying out of pocket, but then that changes what type of patients you're able to actually see with the technology. But then, you know, understanding, you know, step 2 might be which payer are we going to have the easiest way to actually start billing. So, you know, understanding that the rollout may be step by step, and you may start small to just pilot and then continue to grow and learn as you're evolving.
Thank you. And I want to apologize ahead of time. I noticed that the email addresses are incorrect. We will provide via email the email addresses to Ms. Douglas, Dr. Branson, and Mr. Smith. So please do not send the email to those accounts. Okay, so moving along to the next question. So Ms. Douglas, we received...
There is an echo.
Excuse me, there's a bit of an echo. Okay, we received a handful of questions regarding litigation. So, is there increased litigation or risk of litigation when providing healthcare services via
So, this has been a concern since telemedicine first started, and it seemed to me that it was a concern with not a whole lot of evidence behind it. This is not an area that I really track closely, but I do know that, you know, the insurance covers have specific telemedicine provisions, and I know it's definitely on the mind of those who are concerned about the liability aspect, but I'm not aware of, you know, what the situation is with lawsuits or whether patients have been, you know, suing and or been winning any lawsuits related to telemedicine. I do want to take this opportunity to maybe shoot the myth down that we do live in a litigious society, because most patients who are injured by negligence do not sue, but that's the only talking point I'll share on that right now.
Okay, thank you. So this question actually may be open for all of you, but I'd like to start with Mr. Smith. So Lynn notes that physicians from other states are not allowed to practice in Georgia, but she would like to know about nurse practitioners or physician's assistants.
It applies to them as well. So I've been doing a little bit of research with how the VA's model is kind of structured, because, you know, VA nurse practitioner in Georgia can see a patient anywhere, and just trying to research. I don't have a definite answer for that, but I am currently researching to see how is it that they can see a patient remotely anywhere, and, you know, providers and, you know, other healthcare professionals within an organization and a state are limited to just seeing patients within that state. Now, it's different, you know, if a patient actually travels, because we've had a patient travel outside of the United States and we've seen them, but their home of record is actually in Georgia, so, you know, that encounter was okay. So I don't have a better answer.
And I would imagine that the, you know, just like the licensure requirements for physicians are state specific, that the licensure requirements or, you know, supervision requirements, because I know Georgia is stricter with regard to supervision of NPs and PAs. So depending on states and what their state laws and how flexible they are with the scope of practice, there may be differences there.
And I've pulled a list, because I try to track this pretty frequently. I've pulled a list of kind of where all the 50 states are in regards to telemedicine as it relates to how restrictive that state is, how moderately open to telemedicine that state is, and those states that have been doing progressively well. So I can send those out to everyone. I think it's great information to kind of see, where you pan out. I'll send that out at the close of this webinar.
Thank you so much. Okay, so we'll move on to our next question. So Cheryl would like to know, how does Incidence 2 billing affect telemedicine service providers or service provision?
I don't think I...
And if you don't have an answer, we can always get back to that one. Okay.
I'm not familiar.
No problem. So we'll move on to the next question.
Yeah.
And actually, this is a question for all panelists, and I would like you to answer from your perspective. And Ms. Douglas, if you can answer from the perspective of a researcher in addition to a legal professional.
Thank you.
Okay, so the question is with regard to developing a formative evaluation strategy to determine whether or not your practice or your patients are ready to receive telemedicine services. So is there a formal needs assessment or a formative evaluation strategy which should be implemented? And I see all of you shaking your heads, so the answer is yes. And what is that? What does that
I guess I'll start.
Okay.
Yes, definitely. As a clinician, from the clinician side, you definitely have to see the patient. I typically see all of my patients before suggesting a telemedicine or telehealth visit initially, just to get an understanding of why they came in and what their initial evaluation is for. And second, you don't want a person or follow-up patient who would have multiple reasons for the visit. Once again, there may be a time constraint depending on your telehealth visit. So if it's 15 minutes, you can't discuss multiple different issues. So typically, ideally, you would have seen the person initially in an initial evaluation and then follow up with them for whatever you're doing. If it's for treatment, in my instance, would be migraines, right? I evaluate them and determine if their medication is helping or working. If not, then we can switch it to another one. And that shouldn't take more than 15 minutes, depending on the level of severity for that particular problem. So you have to have some sort of plan or idea of what you want to get out, what you want to, and for the patient to get out of that particular visit.
Okay, so from my perspective, I think that we have to look at it from two different perspectives, and honestly, you have to consider your audience from those perspectives. So Generation Xers are more so one-on-one with their providers. They love to see face-to-face, while millennials are more so, hey, I need to see somebody like yesterday, and I want it to have already been over. So they're more so open to technology. What you have to consider with both audiences is that you want to create a telemedicine encounter that's identical to them actually being in your room. And that makes it a lot more comfortable for that, that patient to say, hey, I feel like they heard me, they addressed all my concerns, all my needs were met. And you want to follow all that up at the end with a questionnaire. It doesn't have to be a long, drawn out questionnaire. It can just be a couple of questions. How do you feel that we perform? You're basically fishing for the answers to help you improve what you currently have in place, if that makes sense.
So, and I would say, I think the question did start with or mention something about a needs assessment, and I think that is really important. And I think it's really important to assess the needs from the patients, from the community of providers. I mean, especially when you're thinking about serving rural areas, or if you're a rural area, thinking about who might the distant providers be, and what is the capacity within that community that you might be wanting to partner with. And then, what is the need within the providers that are currently in the practice. And I think that the answers to those questions would be all very different. So finding, what is going to work and meet the needs of all three of those different types of stakeholders, it would be the challenge, but that would also start this ongoing conversation and relationship that would help in the evolution of the service. So, I also have to include the policy side of the evaluation in this question. From a public payer perspective and Medicaid specifically, things like how far are patients currently traveling, and for Medicaid that pays for transportation services to appointments, identifying how a telemedicine program has either changed the amount of travel that people have to do, whether that be their time or their distance in miles. Those are key factors that are going to be important for advocating for better supportive policies within the state to be able to demonstrate where the state may be saving money, or where there are, there's literally no specialist within a certain mile radius demonstrating that this patient may have foregone care completely, but now by telemedicine they're able to actually receive care. Those are the kinds of points that payers or system level people are going to be interested in finding. Obviously, the patient outcomes and being able to show whether there are differences in providing those in-person services or via telemedicine. And I do think the use in the technology is still young enough that we're still learning a lot about what is the most appropriate type of service to deliver via telemedicine. I think we're also, it's been really interesting to follow this over time where the utilization, lots of people had the technology, but utilization and how often providers were using the technology was lagging behind a lot. And so we've definitely seen that utilization increasing, and some of the recent literature has really pointed to some of the programs that, the reasons that patients are interested in telemedicine is that convenience factor. So figuring out and designing programs that really, support that convenience factor, again, thinking about that may serve a different patient population than a lot of us who are focused on underserved communities may be caring for. So, that issue definitely comes into play. But lots of room for evaluation and very important, especially for growing this type of service at the practice level or, at the system level.
Thank you. And that was a very comprehensive answer. Thank you for that question. Excuse me. Thank you for that response. Dr. Branson, we have a question from your perspective since you have excelled as a clinician providing telemedicine services. So one respondent would like to know, what services do you believe to be ideal for telemedicine implementation?
It does depend on your field of expertise.
And you may be needed.
Stated before, I'm a neurologist. So typically, I wouldn't have someone who had an initial evaluation of a stroke assessment do the telemedicine visit. But if I've seen someone in my clinic before for a headache and I'm treating them with a medication and I'm just following up to see if that has helped, then I don't mind doing a follow-up. And sometimes you can say, oh, I'm not sure if this medication is going to help cover them until our next visit, so then maybe I'll do a 6-week visit to evaluate that. So you want to assess the person's capability, like stated before about the differences between the millennials and the Gen Xers. If they are comfortable with using telemedicine or telehealth, a computer or phone or iPad or whatever screen that they would use, and if they do feel comfortable with accessing that and going through that and downloading that information in that software. So even if it may be something simple, I may feel that the person may not feel as comfortable, and you can always ask them. As stated before, also location, Georgia being a much bigger state, if they're fighting traffic and they come in and their blood pressure is really high, and they said, I was just, you know, in traffic sitting trying to get here, and I've caused another problem when they're trying to come in for management or care. So you want to offer that as an option so that they won't have to fight traffic or sit in the, you know, Georgia's heat, or whatever way that mechanism or way that they have to get to your clinic to see you. So you want to look at all of that, and then look at your schedule and your time as well, and determine if you are comfortable with doing a telehealth or telemedicine visit, making sure you have an assessment evaluation that you have in front of you as well, because it's new, it's different, and you know, it may seem, people may make it feel like, oh, I'm talking on the phone, but you really have to do your due diligence and document everything that you're talking to them about. So you still have to do some of the same things that you're doing as if they were in the clinic, and that we may forget that because this is all new to us, and it's a new device. So just making sure that the patient feels comfortable, and that you as the clinician also feel comfortable with performing the initial, the follow-up evaluation.
Thank you. Okay, Mr. Smith, I have a question for you. I know we're coming close. Do all payers reimburse for telemedicine visits?
It's kind of a loaded question. So it depends on the payer, really. And the reason why I say is because we found out that, I'll give you a current example. We were not being reimbursed from Cigna for our telemedicine encounters. And so after a little bit of research, that's how we found out that Cigna had partnered with MDLive and Amwell, and they had chosen them to be the only platforms that they would reimburse you know, for a visit. And but it kind of put us in a little bit of a bind, because the only option that we were able to offer patients that had Cigna insurance were cash paying options, you know, self-pay. And that worked, but if you pay for, you know, if you're paying for insurance, you want your insurance to cover your visit, you know. And you also have to keep in mind that if that's a scenario that you're currently dealing with, you have to have them sign a waiver, and the waiver basically has to state something along the lines that later on I would not go back and use my you know, insurance to cover this visit, because then that creates a pull effect. You know, you got to reimburse the patient for the visit because they paid you a flat rate, and insurance says that, hey, I have a copay of $25, so if you charge them the flat rate of $50, now you owe them the difference. And so those are some of the issues that we found. With Medicare, Medicaid, they're a little bit more tricky. We would not be reimbursed for telemedicine visits simply because we're not in a underserved area. If you are in an underserved area, you could be reimbursed for those visits.
Medicare.
Yeah, right.
Phenomenal. And Ms. Douglas, I saw you shaking your head. Are there any points that you'd like to add to that question about reimbursement? Does everyone reimburse? Do some people reimburse? Is it
so I'm surprised a little bit to hear about this instance with that Marcus is discussing with a private insurance company, and that sounds like the types of things we were hearing when the payer parity law was first passed in Georgia. It doesn't sound like that would comply with what the Georgia law is, but again, I'm not providing legal advice here today. I do in Georgia, I mean, given that we have the private payer mandate, our Medicaid program pays, and then yes, Marcus did hit on some of the Medicare limitations, but yes, in my view, all payers would be paying. That doesn't mean that we don't have a number of telemedicine programs that do rely on patients paying out of pocket, and that's you know, that's been trending a lot lately. But short answer would be yes.
I would also like to add that really quick, I would like to end-stage renal disease, Medicare will pay for telemedicine visits for those.
Thank you. Well, we have reached the top of our hour, and I know Dr. Branson has to leave, so I will ask Dr. Branson, do you have any closing thoughts? And you may be
Okay, sorry about that. I just wanted to add that telemedicine is a great opportunity for patients. I can tell you so many stories. One patient had the view of his backyard as a scenery and setting, and it can really help with de-stressing. And for the patients, they feel more comfortable and almost like you're a part of being there. Like going back to those days when you would do those house visits or house calls, and you can see a lot of different things. You can see if they're home or depending on where they're at, where they're having the visit is in just what their other issues that might be causing some of the problems that they're having. And there was one other question about psychiatry. But yes, it does depend on the acuity and if it would be appropriate for, I think the question was, would it be appropriate for telehealth? Definitely psychiatry would definitely be appropriate for telehealth. It just depends on the acuity level. If it's really acute, severe depression, active suicide ideation, that would not be appropriate. But if it's something stable and you're continuing to monitor along, yes, that would be appropriate. But thank you again. This was a great opportunity, and I really appreciate it.
Thank you. And I will ask Ms. Douglas for her closing thoughts, and I'm also going to ask you to plug the research work that's being conducted by the National Center for Primary Care, and then I will ask Mr. Smith for his closing remarks, and I will ask you to plug all opportunities to partner with.
So thank you for putting this webinar on. I agree that telemedicine is absolutely beneficial for patients, for payers, and for providers, especially when you can figure out those parameters that really make it work. I will plug some of the NCPC work. What I mentioned earlier, the examining health IT adoption, and telemedicine is one of those digital health solutions that we will be asking about. But we will be starting a big marketing campaign to get people to take our survey sometime in September is the plan. So hopefully if you receive an email from us to take the survey, you'll be willing to share what types of health IT you're using, and we are defining that very broadly, from the use of electronic medical records to patient portals, health information exchange, apps, Fitbits, things like that. So really trying to be very broad and inclusive and see where technology is going in the future. So yes, hope that you'll be able to participate with that. Thank you, everyone with Morehouse Healthcare, and thanks to the other presenters as well.
All right, so I guess that leaves me. All right, so initially when I heard about the telemedicine opportunity or idea, I was ecstatic about being a part of it. Last year I was able to attend the, I think it's the ATA, American Technology Association. Telemedicine, I'm sorry. Thanks for correcting me. I was able to attend, it's all right. I was able to attend that, and I found out a ton of information. You're able to communicate with, other individuals that are going through the same thing that you're going through. Some are a little bit more advanced. Some of them are a little behind. But, you can offer advice. You can receive advice, and sometimes you can kind of collaborate and share ideas, which is phenomenal. I would like to leave these closing remarks is that CMS is working very hard to streamline the telemedicine, telehealth criteria for reimbursement. All right, so that's including the clinical performance, member experience is high on their list, drug adherence, operational efficiency, basically be the best that you can be at providing the best telemedicine experience that you can provide. And so with that, that's all that I have. Thanks for the opportunity. Thanks to the other presenters. It was a fantastic experience.